Okay, another light video from Critical Care on Your Team. Hi, my name is Holly, and I, there's a lot of different ways I can see this channel developing. I mean, not only do I really want to use it as an educational tool, period, not only for patients and families and people that have been slightly traumatized by the ICU setting and have all these questions and want to know why things happen the way they do, or because things happen the way they should, and more often than not. But I guess also in a unique way, I can see this kind of working out for new grad nurses that may be in the ICU setting or may consider the ICU setting or maybe in any setting, but not necessarily the ICU. This I have only worked in the ICU as a nurse, well, predominantly. I started off with some radiology background and kind of working a couple months in the radiology department, but I was in tech first and foremost, and then I became a nurse, and then I was in that department, so that doesn't count. But having my bedside skills be geared towards ICU, and more than ever, I mean, we have a lot of new grad nurses, and it is a scary and scarier environment to start off as a new grad. I had a huge benefit when I was a new grad in the ICU, where I think it feels like years of really getting those chronically ill critical patients that weren't going to die, and some of the benefit is that no matter what I did, I wasn't going to kill them, but that they were just chronically ill and they're coming in for their fifth pneumonia this year and it's only February, you know, type of thing. So anyway, I had an opportunity to be a newbie, and now the environment has changed, and it is crazy. It is crazy. I see these new guys coming in, and they're hella awesome for being able to stand the pressure, but I mean, there is some pressure there. And I always have these little tidbits and these things, and I don't know. I do try to be more helpful than not. I always try to leave um, a way for them to feel that at least be approachable to me, that they can approach me and get what they need, and know that they're going to have the benefit of my nursing, understanding, and not at all like I am even the cream of the crop or anything like that. It's not like that, but it is wrong to think that you could have a nurse that's in ICU after a year. It's wrong. It would be wrong for me to think that that nurse, they've had experience that I haven't had. They've come across patients in ways and done things and given drugs that maybe I haven't given, or have had to deal with something that I haven't had to deal with. And so for me to dismiss them because they've only been in the ICU sitting for maybe a year is completely wrong. Um, what I have over a new grad, or what someone that has 30 years of experience in the hospital and ICU settings, and we do have nurses that are there, is that they have this very broad understanding. They can read things like it's written on the wall. Like they can see a patient that yep, that's what that is. Yep, they can call it. Yep, they know it. They see it coming. They expect it. They're just these huge. They're very predictive. They look at the situation and just go, we know exactly what's going to happen here, and you just go, well, you have a crystal ball, or how do you know these things? And it's because they've seen it. And I kind of get it, and how I've explained it is that you kind of get a flavor for patients. Patients have a flavor. We we describe all the things that can come from a patient's body as being some sort of food, or something kind of gross. We're just totally like whacked out individuals, but as a group, we're just totally twisted. But you get these patients and they have flavors, and you go, I know this flavor. I know what this means. I've seen this before. And you start looking, and you're this detective, and you go, aha, see, I knew it. You just know it. And that's where experience over being new. You just don't have enough knowing and enough seeing in order to be like being able to call it, because things aren't textbook. And even though you learn from a pathophysiology book or a nursing book, even those abnormals, the normals that you experience in the clinical setting are not even textbook abnormals. So you have to really be prepared to learn a lot, and can realize and just not let your ego be overinflated and come into the setting saying, I have so much more to learn. And there are people that want to teach you, but you come in with that inflated ego. I'm an ICU nurse, I'm going to do this. I would just say learn from as many people as you can about as many things as you possibly can. Learn how to do a single thing multiple ways. It's not just one right way, although I would say you chart per policy. There are a lot of ways to get the job done, and sometimes you do need that creativity and that flexibility in order to be really effective in your career, and to be able to have some longevity in your career and not let it get to you. You really have to not take yourself so seriously. But with the new grads, I kind of see this channel unfolding to where you might be able to pick up some, and at least you can have some conversation about it. But you wanna really be able to identify abnormals as quickly as you can. You really want to be that detective. Two pieces of advice. First one is that if you see something and just in that moment it looks wrong, it feels wrong, you get that notion, you need to double check it. Look again, look closer, investigate. Don't let something sit on your conscience where you walk past a room and it could not even be an alarm going off. It can't even be an IV going off. It may not be nothing, but it may not be anything. But at the same time, you pass by and it just strikes you as something is not right with that picture. Go look. Go look. It will save you and save a life every single time. Guarantee you. That's number one. I mean, it's not the only way to save a life or save, yourself some hassle. But it's a good way. When you'll have plenty of things to ignore, but when something sticks out and you notice that you've noticed it, stop and go look. The other thing is, look at all the normals you possibly can. Like, look at a normal EKG, look at a normal, x-ray, look at normal chest tube functions, look at normal settings, look at normal labs, look at normal. Find what your normal is and look at normal. Listen to normal bowel sounds, listen to normal chest sounds, listen to normal heart sounds. Listen to normals. Because eventually what happens is those normals become a baseline and they kind of disappear into just nothing. I mean, I go to listen to a chest, and if that patient's breathing fine, I don't hear anything. I mean, I really, really, really have to focus to hear something. But if it's abnormal, because I've heard normal so much, when it's abnormal, it screams at me. It screams. It absolutely is like, oh, what is that? Oh, that's a rub. Oh, that's that. Oh, there's no bowel sounds. Oh, you recognize abnormal really quick. But you have to really be comfortable with what normal sounds like. So, you'll see a new grad assessing, pedal pulses for, a length of time. And you're like, are they there? Are they not there? And usually, nurses that have been around it, they really quickly will assess it. They can't find it. They don't even spend any more time trying to find it. They go ahead and grab the Doppler. They go ahead and mark their pulses. They go ahead and ask the nurse during the report that had the patient before, hey, you're using a Doppler. Are the pulses marked? Can you show me where you found them? give me all the tricks. Don't let me recreate this wheel of learning. That's what report is for. Is tell me how you got it, where you got it, when you noticed it leaving, and become. Don't report is you get all those things that you need to know, but then there's also things that you want to know, and they're not necessarily textbook. They're not necessarily the things that you want to hear. Like you might hear like, yeah, I had to give a patient pain medication. Well, did it work? It didn't work. Well, what else did you do? Oh, you did that too. And what you'll find is that, yeah, they gave Percocet and then turned around and gave morphine and then turned around and gave Ativan and then turned around and gave Benadryl and they turned around and they threw the book at him and the patient's still wide awake. Well, something, that you're going to have a hassle and you need to come in and with that mindset of how do we handle this? This is not acceptable. Or you realize that it really just takes that amount to really get your patient into a very comfortable place. But if you, as a new grad, don't ask those questions and you don't do some detective work, you might give them morphine and you might give them this and you might give them that and it might be spaced too far in between. Then you'll never have. Yeah, it's a nightmare. I remember one time I had a patient that had like an ungodly amount of antihypertensives, and I mean like pill ejectables, everything. And I'm sitting there going, oh my gosh, I'm gonna like totally crash out there. Bottom out their blood pressure. I don't feel like doing this. And so I, within the guidelines, as much as I remember, spaced out their medication. And I didn't just slam them with everything at once. And I struggled for the rest of the night with a high blood pressure in like the 160s, 170s. And so some people you do have to throw it all at. So, you ask the nurse, hey, I noticed, I'm getting a report. I noticed that they have all these antihypertensives. They're all scheduled for 9 o'clock. How did you give it? Did it work? You gave it to them all. They managed it just fine. It barely touched them as it was. I mean, it lets you know a whole bunch, but you got to be aware of those kind of questions to ask and follow up with, well, did it work? I mean, we're not just interested in pushing pills or, giving injections. We're interested in the therapeutic results of all the effort that we do because we need to chart it. Anyway, I hope new grads don't find me condescending. I hope that you find me as another resource and that you find me as a friendly face because I definitely think new grads in the ICU is awesome, and you guys are just awesome for wanting to be there, especially in this day and age. I don't know if I could do it. So, you found yourself in an awesome career with awesome people doing awesome work and saving lives, and you'll learn so much and grow incredibly over the next couple of years. And I'm so happy to be a part of that for whatever that's worth. So, if you guys have any questions, or if you just tune in just to kind of get whatever, and I'll have more to address with you later because I actually have some big topics with new grads too. But anyway. Please take care.